So it's time to have our first Q&A session of the day. So I'll hand over to Laura, if I can ask Professor Beales and Dr. Shehla Mohammed to join us for that Q&A session.
Thanks, Tonya. Yeah, and thanks everybody. Quite a lot of questions coming in, and there seems to be a lot of interest around the injections and the gene therapy that Phil mentioned earlier on. And quite a few questions saying that if gene therapy was trialled and approved, would it fast track the process for other BBS genes?
Okay, I'll take that one. As far as what we call the regulatory approvals are concerned, you have to test each particular gene therapy. It's considered to be a separate drug entirely from any other one. So therefore, it needs to get its own approval. And therefore, BBS1 wouldn't necessarily mean that BBS 10 or BBS 6 or whatever might move any faster. But with time, we would expect that the regulators will become more comfortable, perhaps, with the processes. And there are already noises that are being made by the FDA in the US in particular around perhaps how the actual product, the actual drug itself might be made. In other words, if you develop the process for one particular gene and you then do what you might call plug and play, if you like, and put another one in there, then that process might actually be sped up. I hope that makes sense. But if it's a specific gene itself, it has to gain its own approval.
Thank you, Phil. There's a couple of questions around what stage treatment might be available. So people asking if such a treatment was available, would it be available to those who've got very few photoreceptors left, or those that have perhaps lost all their vision as adults?
Yeah, that's a really good question. I did mention the fact that you have to give this relatively early, and the reason for that is because you have to have intact functioning, or a certain number of functioning photoreceptors, rods or cones in the back of the eye, because what gene therapy does, it prevents it from progressing. What it does not do, it does not reverse it. In other words, once those cells have died off, gene therapy will not regrow those cells. So you have to have a certain number of intact ones in order to prevent that from occurring any further, deteriorating any further.
Thank you. I hope that helps those that asked that question. Now another one, a bit more general BBS question. So someone's asking if the gene type relates to symptom severity.
Shall I start, and Phil, you can join? So I think that's a really understandable question, and I would say just about every person we see in the BBS clinic asks for that information, because once we know what the mutation is, there are inevitable questions about what this means for the future. How will it change? Is it going to be different from the patient in the next room in the clinic? And I think it is a difficult one to answer, although we can make some generalizations. Each type of the 22 BBS genes that we can check for, each of them have a degree of variability. BBS1, as we know, is the most common one, and of the patients that we see. And you could say that it could be at the milder end of the spectrum, but that's not necessarily always the case. I think, Phil, I don't know if you would agree, but BBS1, BBS10 tend to have more problems in certain areas. Also, there are some types of BBS that are more likely to be associated with renal issues. But I don't know whether, from your extensive experience, you want to say a bit more on that front. So that's what we see in clinic, but it's a difficult one to answer, other than in very broad terms.
No, I think you've answered the question. I don't really have much more to add. As you say, BBS1 and BBS10 are the two contrasting ones, in terms of, you know, the onset perhaps might be earlier, and sometimes some might say the severity. But because some of the other genotypes are relatively rare in terms of the numbers of patients, it's difficult to do that comparison. So you're absolutely right. Thank you.
Thank you. Conscious of the time, but we got time for another question, and this might link to what you were talking about, Dr. Shehla Mohammed, about pregnancy and inheritance. Somebody is asking, can BBS affect pregnancy? And they put, I have been trying for the past year with my partner. I'm not sure if that means from a fertility point of view or the inheritance point of view. So if you could just expand perhaps generally a little bit more.
Sure.
Thank
So
you.
we do recognize that the fertility can be affected, generally speaking, in most patients with BBS. It is probably more commonly recognized, I think, in men with BBS, but equally women with BBS can also have other related involvement of other issues, like many female patients that we see in BBS clinic may have polycystic ovary that can affect their hormonal levels and their ability to conceive. But there is a lot of variation, and there are ways that, if further investigation are needed, then we would always try and facilitate that, making sure they, other than the endocrinologist who's usually present in clinic, to suggest more specific investigations for fertility. We do have many families where individuals, either males or females with BBS, have had their own children. So, but it is a question that can be explored further if there have been difficulties in conceiving.
Okay, thank you, Shehla.
Hi there. So in light of some of the questions around the fact that gene therapy is targeting specific genes, so we've had a comment from Tim Ogden in the States. They've got their BBS conference coming up in July, and he said they're working with the Foundation Fighting Blindness on some presentations on approaches to treatment for people with advanced retinal degeneration, regardless of the gene. And I just wondered if you'd got any comments on that.
Apart from to say that it's really exciting, and there are several ways of thinking about this, I don't know which specific presentations that he's talking about, so I think it's better to ask him directly.
Okay, so these will be presented at their conference and be made available more generally. It's just, I think, just answering some of those questions of people that are feeling, with the target being BBS1 or BBS10, that there is wider research going on as well in therapies that are non-gene specific. So that's exciting.